Thank you. Thank you for coming on a Friday. This is a pressure ulcer. It's an ischemic injury due to prolonged unrelieved pressure that results in reduced blood flow and tissue necrosis. This device, this $200 accelerometer, can prevent that. As a plastic and reconstructive surgeon, I've taken care of hundreds of these patients over the past 25 years. And by the time I see them, typically the tissue necrosis is extensive. That's because skin is relatively resistant to tissue ischemia, but muscle and fat is not. So they may present with drainage from a small wound, but then in the operating room you find extensive undermining and tunneling. These patients typically will have a reconstructive procedure or will be put on a wound vac or have standard wound care dressings, and will be asked to offload this wound, which is typically a trochanteric wound or a buttock wound, for up to 3 months, sometimes 6 months. That means prone for 3 to 6 months. Put yourself in that situation. You've had a recent spinal cord injury. Now the doctor is asking you to stay on your stomach for 3 months. Or you're in a sand bed for 3 to 6 months. And in reality, sometimes these ulcers take a year or more to heal. And the recurrence rate, once they do heal, is over 50%. I've used every type of seat cushion, every type of offloading pressure device, every type of air mattress, sand beds, wound dressings, enzymatic debridements, and they all help. But every study has shown that the single most important factor to prevent hospital-acquired pressure ulcers is turning the patient every 2 hours. So how are we doing? Not good, not good. The best study shows a documentation of less than 2/3 of patients meeting that every 2-hour turning protocol, and most of them show less than 50%. And that's documentation. That means they're looking at the medical record retrospectively, and it's documented that they were turned. So we don't know what that means. That means the pillows were fluffed up, an IV bag was stuffed under their hip, it wasn't done at all, we don't know. That's just documentation. So if you look at the cost of pressure ulcers, it's staggering. Over $11 billion a year. I mean, it's not COPD, but $11 billion a year in hospitalization, surgeries, wound dressings, beds, litigation, decreased Medicare reimbursement to hospitals. And it's estimated that for each event, hospital costs will increase $50,000 for that patient on average. If you look at all adverse events that occur in hospitals, hospital-acquired pressure ulcers is more than all of them combined. That's falls, DVTs, hospital-acquired pneumonias, catheter-associated UTIs, central line sepsis, more than all of them combined, the financial burden. And in one hospital I looked at, in 5 months, over $350,000 spent on the care of patients with hospital-acquired pressure ulcers. These are patients that came into the hospital without an ulcer and got an ulcer while they were hospitalized. So that's a great reason for me to undertake this study, how this device can prevent that, right? It costs a lot. It'll be cost savings. And certainly, in my experience in dealing with trying to get a trial of a device, that's very important. That's really not the driving factor. You see, I see these patients and they come in like this. They're malnourished. These are huge protein sump wounds. They drain a lot of proteinaceous fluid. It's very hard to catch up nutritionally. They're anemic, they're neglected, they're depressed, they're socially isolated. Either by prescription or by choice, they don't get out of bed. They very rarely go to the primary care physician, and these smell really bad. They smell so bad when they come into the office for care, sometimes we have to put peppermint on our masks just to provide the initial care for them. So it's a really emotionally debilitating as well as physically debilitating problem. And so I've been interested in this, and when I found out about the Leaf device, I became very interested. I knew exactly what I wanted to do for my project. So how does it work? You place it pre-sternally on a debilitated patient or a patient at risk, and it's basically an accelerometer that measures patient position. That information is relayed via radio frequency to a simple antenna that's plugged into a standard outlet, and then it's relayed to a user interface at the nurse's station. It's extremely intuitive. Both the sensor and the user interface show when the patient has been turned in green, when the patient is due for a turn in yellow, and when the patient is overdue for a turn. It also shows whether they're on their left side, their back, or their right side. You can customize it so you can cross out the left side if they have, let's say, a surgical site or something. You can increase to turning every hour. Let's say there's a patient who has a perfusion issue, maybe heart failure or something, and you want to turn them more often. And so the feedback from nurses on the studies that have been done, this has been very positive. And very little alarm fatigue. You know, they have a lot going on, the nurses. This integrates very well in the ICU setting. So how does it reduce hospital-acquired pressure ulcers? It ensures that the patient turning compliance is being adhered to. It ensures and standardizes the quality of turns because it measures actually the angle that the patient is turned. So it won't register a turn if it's not a quality turn. And it improves documentation, which is really important from a medical legal aspect, and also important for feedback, daily rounds, trends. And so it has a lot of use in staffing. The two studies that have been done, one in Stanford and then a smaller study, have shown, again, about a 65% compliance. They put the leaf device on the patient. They don't tell the nurses what it's for, and the device measures about a 65% compliance in turning. With the user interface feedback, up to 98%. And in the study done at Stanford, it reduced hospital-acquired pressure ulcers 70%. So not a lot of data. It's a new device, but very, very promising. So my goal was to initiate this trial at our regional hospital, utilize the skills learned from the Leadership College to push this forward, and use the data that we obtained through the initial trial to continue its use, to use it in other settings like postoperative setting, patient ambulation, outpatient care for paraplegic patients in their chair, you know, giving them some kind of biofeedback or alarm to when they need the pressure relief. We started in April, kind of utilizing the skills from the college, which have just been amazing. And at 60 years old, I didn't think I should have done this 20 years ago. But I gathered a core group of key clinical administrative people. I introduced them to the LEAF educator. We had several meetings. They were excited about it. We had continued meetings. We developed a budget. We developed a business plan. We developed metrics, analytics. We identified which patients would be included, and I don't want to go through all those things. We established the pre-trial turning compliance measure where the nurses aren't actually getting feedback. We established a computerized, or we are working on establishing a computerized learning for the nurses. IT had gone through the units, would be the MICU and STICU, had uploaded the portals, had done some minor modifications with the ICU to set up the network, and it tested it. That's been done. And we got legal and administrative approval for the project. The go date was September 15th. About 10 days before the go project, it was put on hold. So I'm continuing to work with the administration. I've had some positive feedback from some of the people I've talked to there. And I think once some other issues are settled at the hospital and once some other issues are worked through, certainly maybe the next annual budget, I have a very good chance of pushing this through. I'm also talking to another hospital system about it, and I'm working with UVA to see if they are interested in doing it, because I have a clinical professorship there. So it's promising, and I really think it holds something that could really make a difference so that we don't see this. Thank you.